entails basic life support. No drugs, no advanced airway equipment. And it is a foundation for saving what? Lives for those who are under cardiac arrest. If you have a patient who has arrested and you do the basic life-saving maneuvers, your patient is likely to survive. Even when you go from basic to advanced, your patient is what? Likely to survive. So in our learning objectives today, we shall have to be in position to describe the importance of high-quality cardiopulmonary resuscitation and its impact on survival. Why do we say high quality? We shall look at that. High quality CPR. What are the qualities of a good CPR? Not so. And these qualities, once you do them good, the way they are, as the word says, high quality, that gives you a very good chance for the patient to survive, or at least to have return of spontaneous circulation, what we call ROSC. If they are not of high quality, then the chances of you reviving the patient's heart is going to be very minimal. Your patient is not likely to survive. So also to describe all the steps in the chain of survival. And this chain of survival, as the word goes, the chances of this patient surviving is as strong as the weakest link in that chain. If, let's say, hold a hand, hold my hand with your left hand, hold me. Okay? The four of us to move together. Okay? If he decides to drop off here, that means we shall not be moving what? In the pattern we are supposed to be moving. You'll realize you have already left somebody out. Now, one step has already been left out, then the chances of this continuity of care for that patient is going to be minimized. And so the survival chances of this patient goes down. And that's why it says, for the patient to survive, this chain of survival, the links in between should be as strong as possible. So if there's a weak link, meaning one step has been omitted in that chain, then the patient's chances of survival will go down. Now, also to apply the basic life support concepts of the chains of survival. When you get to that scenario, then you look at how to appropriately respond. And this is where we are. In this aspect, we have got two scenarios. There's one inpatient, cardiac arrest, and out of hospital or in hospital, cardiac arrest. The IHCA is in hospital, cardiac arrest. And the other one is out of hospital. Meaning here, it has happened within the hospital setting. And in the hospital setting, you have got some teams. You can call them emergency response teams. We have code duty, and then the rest of the team. So early in hospital cardiac arrest, we have early recognition and prevention. So here we have emergency response team who will be moving, let's say from casualty. I can visit casualty, get to find out which patients are critical at that point. And those who are critical, at risk of having cardiac arrest, I make sure I reverse the processes of them getting into cardiac arrest. And of course, the causes of cardiac arrest, we know them. The H's and the T's. Those are reversible causes. The non-reversible causes, you can't do much about them. You have only to target the reversible causes. In the H's, we can look at maybe hypertension, hypokalemia, hypovolemia, hypothermia, and the rest. Okay. And then when they look at the T's, there, toxins, these are toxicity, maybe of drug overdose or anything else. Which one? Tamponade, yes. Pneumo, tension pneumo. Okay. What else? Thromboembolism. Okay. So, if you realize what is causing this patient to be critical is one of the H's or the T's, by the response team here, early recognition. You recognize that what's your name? Paul. I go to casualty, I find you are the patient in casualty with hypotension, for example. BP is maybe 80/40. You're diaphoretic, you're desaturated. And then I reach there, I get to rectify the problem and also treat the cause. And then you'll know that this patient is not likely to get into cardiac arrest because there's early recognition of the problem and you've prevented it from occurring. But if it does not happen that way, then you're going to activate the emergency response team. These emergency response teams are the code blue team. In other hospitals, we have got codes already in, like you have it, you guys have watched this medical series. Sometimes they code blue, even when you're having your breakfast at the restaurant or somewhere else. You just take off and run to where the code blue is being alerted. You go there straight. And here, you respond to the team. Now, when you reach here, high quality CPR is what takes place there. High quality CPR meaning all the qualities of a good CPR, like compression rates, has to be about what? 100 to 120 chest compressions per minute. You minimize on interruptions. You allow chest to recoil back. Some people just press the chest once and then they leave their hands down there. You don't allow the chest to recoil back to create that negative pressure. It pulls back the blood from the other peripheral areas of the body to the heart. Then it gets pumped again to the rest of the body. That's why it's very important. You allow the chest to recoil back to fill up the heart. Then you can pump that blood again to the rest of the body. So there are so many other qualities that you shall look at. I have them. Then when you come to here, early defibrillation. I have an EAD here I've come with. Where is Brenda? She has not come. Do you have AED here in our lab there? This is automated external defibrillator. You have one? You're not sure? Okay. I've come with this. It's still okay. So once you have this, you can still do your early defibrillation. And then the rest, once you have achieved, let's say, return of spontaneous circulation, you then go for post-cardiac arrest care. Post-cardiac arrest care, meaning there are parameters that you need to control them vigorously so that this patient does not get back into rebound or refractory cardiac arrest. So you go to post-cardiac arrest care. Then recovery is long-term. There's also immediate and long-term, but most important is the long-term bit. If you have got severe brain injury or severe brain complications to the patient, you are likely to have this patient undergo rehabilitations with a lot of maybe speech therapy, occupational therapy, a lot of things, because it has affected the patient severely, and the patient takes time to recover from that cardiac arrest. Now that is in recovery. So out of hospital, most of the time, you get to witness it like it's happening already. You don't have time to do the surveillance, to maybe categorize the patient and say this is patient who is in impending cardiac arrest. They just present like we are right now. We are in class like this. Somebody will just collapse. We don't know our parameters right now, right? I don't know my blood pressure, my saturation, or anything. But all of a sudden, I'll just collapse here. And then you start already with the emergency response. You don't have this early recognition and prevention. It's not there. Out of hospital. It can be witnessed or unwitnessed cardiac arrest. You understand the difference? Yes. Witnessed is like you've seen it happen. Unwitnessed, you found already the patient unconscious. And so, why do we say it is very important for you to know the difference between the witness and unwitnessed? This will gauge the time you need to spend on this patient. If a patient has stayed 10 minutes unconscious, not breathing, no pulse, no nothing, you'll find the patient already blue and everything. Yes, you do your resuscitation, but come a time, 10, 15 minutes, you call it off, right? But if you've seen it happening, you can give it more time, maybe 30 minutes. And that also gives you better chances of trying to find out the real cause. Unwitnessed might be hard. You need really just to look at the H's and the T's. Code blue team. These are people trained in cardiopulmonary resuscitation, and it is in an hospital setting or emergency care. Because when I call you, you're not a code blue team. You don't have any idea about cardiopulmonary resuscitation. Trust me, you come here and just even disorganize the team the more. Because you'll be so scared. But code blue team, they have been trained on how to handle certain situations. Somebody reaches like this and distribute roles immediately. And so when I tell you, James, you are going to be a team leader. Paul, you're going to be CPR coach. Sorry, your name is? Yes. Benina. So, Benina, you're going to be. Benina, you're going to be a timer. Your name is? Richard. Richard, you're going to be on IV meds. Your name is? Geoffrey. Geoffrey, you're going to be on a defibrillator. Okay. Your name is? Tumune. Tumune, you're going to be chest compression. Okay. You and Emma, you're going to be on chest compression. I get it. I'm distributing these roles because I've just come. We are called blue teams. Okay. We have come, and when I tell you your role, you need to communicate it back to me in a loud and clear voice. Nobody should be shouting in the code blue room. Simply because the communication has to be clear and well understood, and in a closed loop version, communicated back to the person who has given you the role, so that you reaffirm that you have understood your role. If you're not comfortable with the role you've been given, okay, let's say I've given Geoffrey defibrillator. Probably he has last used it during the training, and this is maybe 3 years down the road. He has forgotten on how to operate it. He will tell me back, so and so, I'm not comfortable in this. Probably I can do chest compression. Then immediately I switch your role. I'll then say to Muine, take over defibrillator if you're good at it. And then Geoffrey comes back to chest compression. You understand? You must know your role and you must be confident of executing it when it comes through. If you're not comfortable, make it clear that I'm not comfortable with this role, give me another one. And then I can assign you another one immediately. Not me, but the team leader at the time. The one who assigns duty or responsibilities is the what? The team leader. And the team leader has a role to stop chest compressions when he sees that something wrong is happening. If the CPR coach is not doing his role, but must be in a very respectable manner. You're not going to say, because you've been quiet for long, well, let me just take over. You get it? Say, no, hey, so and so you've forgotten this. I think let's do this in a respectable manner and a very tone voice. So yeah, that was your question, yeah? Yes. It explained a lot, but this thing is a reality. It's just good when you get to see it being done. That's when you'll appreciate it. But anyhow, this is a training, and this is where it starts. By the time maybe you get to specialize, let's say in emergency medicine or in critical care, it becomes part of you. But in practice, still you need to know it. Some people, when it happens in theater, we need as many people as possible, especially for chest compression. Others run away. They just take off. Kabisa. Now, so recovery, in this case, you said there's no what? Early recognition and prevention. You only witness it and get to start chest compression, defibrillation, advanced resuscitation. Now, in advanced resuscitation, this is now where you use medications and advanced airways. Advanced airways, you mean you're going to to use endotracheal tubes, mask airways, tracheal tubes, or esophageal intubating tubes. Those are the advanced airways. OPA, or oropharyngeal airway, is not an advanced airway. Nasopharyngeal airway is not an advanced airway. You get a difference? Okay? Advanced airways, endotracheal tube, laryngeal mask airways, tracheal tubes, esophageal intubating tubes. So those are the advanced airways and the medications you're going to use. Now, depending on what is causing this cardiac arrest, will also determines whether to use which drugs. Okay. If it is PEA, for example, causing the cardiac arrest here, which medications are you going to use as your first line? PEA, pulseless electrical activity. Pulseless electrical activity. Last time I explained, pulseless electrical activity is you're able to see electrical activity on the monitor. Let's say the heart thing on the monitor. However, when you feel the pulse of this patient, you're not feeling anything. Okay? Meaning there's no pulse. So you're going to do what? Use adrenaline. Even in asystole, you're going to use adrenaline. Asystole is more or less the same as PEA. Only the difference is the electrical activity you're able to see. But the management is the same. CPR, adrenaline, until you get back the return of spontaneous circulation. If it does not happen so, then you are likely to maybe call off the resuscitation, or if it has changed from PEA, which is pulseless electrical activity, seems to be normal sinus breathing, but it has changed to maybe ventricular tachycardia, pulseless, or ventricular fibrillation, then you can go from adrenaline to defibrillation. There's what we call CESA. You have a marker? Well, class reps. They are not organized. Where is it? The other side. We don't have any in the back. CESA, by that I mean there's double S first, and then E, okay, and then S, and then A, and then S, and then E, and then S, and then E. Rather A. That's E is A. Okay. CESA. The first S which is in CESA, there are double S, There are two S's there. Now, those two S's, if you find the patient has got, let's say, shockable rhythm. The shockable rhythm is there too, right? This is what we look at. If you have read, that's what also the book says. And that is what is in practice. As far as the practice of this SCLS is concerned. Research is ongoing, but these are the two shockable rhythms. Pulseless electrical activity, pulseless ventricular tachycardia and ventricular fibrillation. Okay. Now it's coming to this CESA. The first two S's are the shocks that you give this patient. Let's say your patient comes with pulseless ventricular tachycardia. You realize this is a shockable rhythm. You shock the first time. After shocking, that is your first S. Okay? After shocking, you get back to cardiopulmonary resuscitation straight away. You don't waste more time until the AED again alerts you after about 2 minutes. Each cycle takes about CPR cycle, there are 5, which is 2 minutes. Okay? After 2 minutes, it will keep alerting you every 2 minutes to check rhythm and pulse. Okay. Now you realize it is a shockable rhythm. You give your first shock, which is the first S, and then resume what? Chest compression straight away. After resuming the chest compression, 2 minutes have elapsed. The AED has warned you, and you have checked the rhythm is again what? Still shockable. You give the second shock. That's the second S in the SESA. Okay. When you shock, you again resume what? Chest compression straight away. When you do that chest compression, after 2 minutes again, this AED will alert you again and tells you stop chest compression, analyzing rhythm and rate. AED. That's why it is very important. The AED you attach onto the patient as immediately as the right. Okay. And for it is automated external defibrillator. Automated by itself, it does everything by itself. Okay, it can also give you guidance. It tells you what to do the next step. That's why it is automated. So it tells you stop chest compression, analyzing rhythm. So you stop, everything else stops, analyzing the rhythm for about 10 seconds. Okay? After the 10 seconds, it tells you this is shockable rhythm. Now when it tells you that, you have to prepare. If it tells you shockable rhythm, it tells you preparing for a shock. It will actually talk to you. Preparing for a shock. As it is preparing for a shock, it will again tell you when it's ready to give the shock. And tells you everybody clear, giving a shock. Some are, it gives you automatically, some tells you to press that button, which we shall look at in the session. Okay. Then if it gives the shock immediately, you resume the chest compression. We already reached the second S in the SESA system, right? Now there's E there. After the two shocks, after the second shock, you have resumed your chest compression. Then it'll tell you, now you must know within yourself that we are now going to get to epinephrine. You're going to give adrenaline. That E is epinephrine. Okay. That epinephrine you're going to give 1 milligram if it is an adult. It's just 1 milligram. The vial is having 1 milligram. Small vial. 1 milligram per meal. It's a concentration of 1 to 1,000. If you redilute it, maybe to use it in children, then you can redilute. But for adults, 1 milligram. Now, after giving adrenaline or epinephrine, the cells are now there. That third S. You have analyzed the rhythm. The thing once that is shockable again. You give your shock. After giving the third shock like this, the person giving IV med need to prepare for the amiodarone now. That A in the SESA is amiodarone. The first dose of amiodarone after the third shot is 300 milligrams. You have seen amiodarone before? No? I thought I'd moved it some, but it's not here. But we have it. In the crash carts, you know crash carts? There's a trolley that is in casualty or emergency unit or in ICU or in theater that has got emergency drugs. Start piling from up emergency drugs, other meds, maybe antibiotics, and then airways, and then other things like urethral catheter, NG tube, and all that. There are chambers there. So you just look at it and pull whatever you need at that time. Because it is an emergency, you move this trolley while the emergency is happening. So that you don't have to run. If I ask for amiodarone, it is already in the crash cart, just pick and give. You don't need to run to pharmacy or send the patient to go and buy from outside pharmacy. You don't have that time. That's why the crash cart is very important. You have it well stocked and you keep checking on a daily. You keep checking it, making sure if in the crash carts you have compartments, you have partitions for the drugs. Amiodarone here, calcium gluconate here, sodium bicarb here, benzodiazepines there, like that. Different chambers. Second one, you can have other things. So if in each chamber, you're supposed to have maybe, let's say, 5 of these meds. Amiodarone 5, benzodiazepine 5, depending on which one's available. Epinephrine, like that. Adrenaline. So you have to have those numbers. The moment you use one in the crash cart, if you done with resuscitation, you come back to your crash cart, look at what you have used, document them, and then refill. Because an emergency is likely to come anytime. So refill immediately and have it updated at all times. That's what we do. Okay. Where was I?
First dose.
Epinephrine. So the third shock, amiodarone.
Yes.
Then the fourth shock, now that's the S is the shock. Okay.
The fourth song.
The fourth one. Yeah, that's the fourth now. Everything is being guided by this AED. Okay. This AED, as you give the shock, you should know which next step you're going to. So that you prepare. If you're going to give the medication, the next thing, you have to what? Prepare it immediately. Let's say you have given your third shock, and you're not sure now what to do next. Then the team leader can actually guide the person giving IV meds. Tell you now, you know what? Who was there? Penina. You are on IV meds, right? Say, Penina, prepare now amiodarone, 300 milligrams, ready. Because you have given your third shock. The next thing to do is amiodarone, 300 milligrams. Then after the amiodarone, you're going to give your fourth shock, if it is still shockable. After the fourth shock, you then go to epinephrine. Again, one what?
1 milligram.
1 milligram. After that, if it is still shockable, you're going to shock and then prepare your second dose of amiodarone. But this time round, you're going to half that to 150 milligrams. Your second dose of amiodarone is going to be 150 milligrams. And that is how you're going to be managing shockable breathing until you revert this back to sinus breathing. Okay. What is our pacemaker in the heart? Sinatron node. And remember, in the shockable rhythms, these rhythms are not originating from the sinatron node. They are in between the AV and the bundle of E's, but especially on the AV node. So, until you get back there, that's when now you probably are likely to stop until you get back to the sinatron node, where your pacemaker is. Yes. Yes, I've just given you a scenario. You have given a first shock. After giving the first shock like this, because I'm going to tell you, shock before you deliver your shock, you make sure everybody is clear. There's no electrical appliances attaching onto the patient. The patient is not being given oxygen. Okay, everyone has cleared, and you confirm by saying it loudly that clear, clear, clear. Everyone clear? Then you have to probably say yes. If it is yes, then you shock. Because if you shock the patient when I'm still touching the patient, you're likely to shock me as well. Now, when you do that shock, you resume chest compression immediately. And this is instructed by the team leader. Or if not, the person doing chest compression, rather, who is the CPR coach, will instruct the chest compressors that after the shock, immediately do what? Resume chest compression. Chest compression has to be ongoing, constantly. But there's clear communication. Okay. I tell you, okay, Geoffrey, get ready with that defibrillator. We are going to give our first shock. You prepare your energy in terms of joules. You can select if that is the manual. If it is automated like this, it just delivers the already defaulted energy in the machine. After delivering the shock, I'll tell Penina, prepare your medication. If it is epinephrine, epinephrine. If it is amiodarone, amiodarone. If the guy is compressing, I say, okay, or transport, who was the CPR coach, right? We'll tell those chest compressing, resume immediately after the shock. Yes. The amiodarone epinephrine can go on as the chest compression is ongoing. But what matters is the shock has been delivered, then prepare the next dose of any other medicine that you're giving and give.
How many chest compressions do you do? How many do you do?
If the patient does not have any advanced airway, you're going to do 30 chest compressions to 2 rescue breaths. If the patient has got advanced airway, you're going to give how many chest compressions? It must be in the range of 100 to 120 per minute. But the rescue breaths will be 1 rescue breath every 6 to 8 seconds. Okay, meaning you're likely to give almost, let's say, almost 10 rescue breaths per minute, right? Because 6 seconds. And how do you know I've reached 6 seconds? I can start by saying, since we are in 4th year, I'll say 4th year 1, 4th year 2, 4th year 3, 4th year 4, 4th year 5, 4th year 6, 1 rescue breath. Then I go back 4th year 1, 4th year 2, 4th year 3, 4th year 4, 4th year 5, 4th year 6, another rescue breath. But the chest compression is what? Constant. It's not being stopped because you already have an advanced airway in place. If you don't have an advanced airway in place, those doing the chest compression, you have to count it loud and clear. Don't say, No, it will not guide the person giving the rescue breaths. You can also easily forget, and the person will not know where have you reached. You can say, you're only in 15, but you're dealing with an adult. You have not reached 30. Then I'll give you my rescue breaths. 1. And the rescue breaths, you don't need to give it 1, 2. No. You give that rescue breath in almost 1 second. You press 1 like this. A second is about 1, 2. That's all. So you give it 1, 2. 1, 2. Like that. 1, 2. You don't do 1, 2. Continue just 1, 2. No, you're too fast. There's a rate for that. You give it in almost 1 second. So, chest compression has to go on. Give the shock, resume it immediately, but it has to be of high quality. And then, yeah.
Excuse me.
Yes.
What if the shock is not, the breathing is not shock?
If the rhythm is not shocking, it is simple. Chest compression, adrenaline. Chest compression, adrenaline. Adrenaline is a drug of chest. How do you tell it's shockable? And this is shockable rhythm. Are you seeing it on the monitor? Are you seeing pulseless ventricular tachycardia on the monitor? Or are you seeing ventricular fibrillation on the monitor? These are the only 2 shockable rhythms. And if you're to shock, you must have had your defibrillator available, whether automated or manual. And by the manual, you must know how to use it. Automated, you just have to know where to attach the pads. Then the rest is pouring it on and all that. It just works for you. You understand? The question is, how do you know it is shockable? Then you look at the pass or the rhythm being displayed. Not so. Yes. Did I answer your question? Yes. Somehow.
Because I don't know how to tell the rhythm.
Okay, we shall look at the rhythm. So yes, we have this chain of survival which I have looked at. And remember, the prevention and preparedness came because of in-hospital setting. You have recognized it early and then you have prevented it. If it is out of hospital, you can only get to perform on already setting cardiac arrest. And then the rest follows. Do you remember this guy? Erickson cardiac arrest. Did you read anything about him? When did it happen? Euro 2021. But this was last year. Was it last year or the other year? Last year. Only last year. 2021. But yeah, those who like soccer. We all saw what happened. This guy just from nowhere collapsed in the field. And people were wondering what has happened. Did anybody shoot him or kick him or anything? No. Okay. This is what happened. This guy collapsed because he got into ventricular fibrillation. He got ventricular fibrillation. Ventricular fibrillation does not warn you. And in ventricular fibrillation, the heart just pivots like this. It doesn't pump, just pivots. And there you don't form any blood pressure. and there's no perfusion into the brain. And these are active guys. They are running. He has been playing soccer. I mean, he has just collapsed. He was fully fit. He got cardiac arrest. He was resuscitated very well. And right now, he's back on his feet. The guy is performing miracles. You guys who watch soccer, yeah. This is what it means.
He made beat Barcelona yesterday.
This is what it means. So if you have everything, you're prepared your things, you're ready for it, you can easily save a life. And you get back to say, yeah, I think I didn't waste time in medical school or whatever. So this guy was resuscitated very well. When they realized it was ventricular fibrillation, immediately shocking him to CPR, shocking him until they got into that state where he got off the vent and got to normal settings. Okay. And he's back with us.
Yeah.
You know the world is a global village. I can communicate to anybody from anywhere. So I mean, he's with us. Okay. Somebody else?
When someone gets like fibrillation,
Sorry?
like that makes someone,
Yes.
is there a likelihood of him getting it again because he has gotten it once, or it doesn't have
The chances are rare, but you must also know what caused it. And I'm pretty sure it's under follow-up by cardiologists. Because things to do with the heart, you cannot take it for granted. Heart, brain, kidneys, you must always be in check. So now that it has happened, he could have also had issues to do with ischemia, because some part of the heart was not being supplied well. So the entire functionality of the heart may not be that good. Actually, our worry was this guy would never get back onto the pitch and play again. But I think from their own assessment, things have been, he has been like okay to continue with soccer. So I'm sure he's also still under follow-up closely, so that he does not get into other issues. And just before you say anything, as I said, this thing, ventricular fibrillation per se, does not warn you. Like if I do your clinical assessment, parameters wise, I examine you, I find everything is normal, and it just comes out of nowhere, presents like that. And you know these soccer guys, they're always under intense screening, intense examination. Everything is there, from what they eat, how their muscles work. They can go compartment by compartment of the muscles, system, organs by organs. Yes, there's no joke, my friend. These guys are well screened. Maybe the problem is out there in Africa. Probably you've been drinking yesterday night. There's a big match today. You're a soccer star. Say, this man is fit. But they just take your blood samples, find the level of toxic, whatever in your system. You benched or you're disqualified for that match. Even if you're like they call it what? MVP, most valuable player, yeah? You still be left out. Because standard wise, you don't qualify. Yeah? Okay. You were saying something before
Yes. I'm moving around and then the back of get cardiac arrest.
Yes.
On the road, maybe. What can I do?
There's no what?
Equipment around. What can I do?
There's no equipment around.
Yes.
Now you guys you're thinking outside the box. Okay, which is good. And this is not anything new. It's well documented. People are doing it. It's just that you need to know what to do. So you get cardiac arrest. Are you the one who is in cardiac arrest? That you want Anyway, I'm assuming you're conscious. Your phone, somebody has collapsed. What do you do? The first thing is you have to verify the scene. If the patient has collapsed in a pool of blood, you don't have protectives. You're not just going to touch this patient. You don't know. What if it is Ebola or an hemorrhagic fever? You have to make sure you're safe to approach the scene. If you're safe, everything is in check. You have your protective. You go and check for the response. Tap on the shoulder. Hello, hello, hello. Are you okay? Talk to me, talk to me. No response. What do you do next? Okay? You shout for help around, nearby. You're not just going, boss, what are you doing? You're just here alone. You'll be okay. I'll come back. No. Okay. Shout for help, call for help. People have come. Okay. If they have come, or maybe you have shouted for help. As they come, you start your chest compression. Huh? There's what we call chest compression only CPR. You only chest compression. As you have called for help, you have shouted. Even when you're doing chest compression, you're still shouting, help! Help here, help. People might come. If they don't come, do what you can. You have done maybe 10 minutes constant. No response. You leave. At least your conscience tells you have offered something. You have tried. But because of resource constraints, human resource, that is, you're unable, you got tired, you can't push anymore. I mean, boss, we meet.
Doctor, in Uganda here,
Yes.
you might end up in the police. They find you are bailing on somebody, they would understand what you're doing. You say you are being strangling this man. So we are worried for our lives because we are not safe. Safety is not guaranteed with them. Then also, I was asking another question. Clinical, how can I say that somebody is in a cardiac tachycardia.
Okay, that one is hard if you don't have these monitors. If you don't have the monitors, it's going to be hard for you to assess clinically. But at least one thing I'm sure of, you're going to be able to check to detect irregularities in the pulse of this patient. But you won't be able to say, maybe this is atrial flutter, atrial fibrillation, or ventricular fibrillation. It will be hard for you. Okay, it will be hard. Does it make sense?
Very.
It will be hard unless you have a monitor. And if not, move this patient to a nearby hospital as soon as possible. Have a monitor attached. If they cannot do an ECG, that means you also need to know how to analyze an ECG. You have done the ECG, it is here, okay. So what? This ECG. You understand that? Yes, you must know how to analyze it. Sorry? Keys of life. Okay, things to do with movies. It can help guide you, but I don't think you need to take everything as the truth. You've ever seen situations where they put like central lines here? These are not central lines. Okay, they're just showing you that they have done something. In fact, Nigerian movies are even the worst. They can do anything, I tell you. But if you have this medical background, you'll be, this guy is no, this is not true. But Keys of Life, now we have modalities. There are modalities where we use, I can give you scenarios. You have relatives. It can be your own children, or your own brother, sister, mother, father, uncle. This person has collapsed. You're not sure of their health status. But if you trusted them, they might survive. Unless they have your dates or anything. But Keys of Life has got other risks of infections. can transmit infection, especially in this era of COVID and TB and whatnot. You get a whole package of it and you go. But we have other modalities. Other people advise you use handkerchief. You can put in the mouth and then blow, do the kiss of life. But we have face masks or pocket masks. These pocket masks are like this other normal mask. But it has got an elongation of the connector here, where you just connect your tip and you have seen incentive spirometry before? That one is for exercising lungs. You blow. Okay. So it is a bit elongated. You don't have direct contact of your mouth to the patient's mouth. But there's this conduit for you to at least make a good seal and then blow the air through that. Okay? You can use that.
This scenario where someone
John. You can already given this situation. Maybe this is your friend, your girlfriend, your wife. You were there swimming together in the water, and then somehow she drowned. Yes, inside. You also don't know how to swim, but you try and pull her out. You can't give the kiss of life. After all, you have probably kissed her before. Also, if it is your child, you can also do direct kissing. You understand? If it is your mother, you can also do the same. If it is distant relative, you don't know their status, health-wise. You know, you have to gauge. If the situation okay for you to approach, that's it. Yes.
Doctor, about the patients who get apart from accidents, I've seen because people come, but in situations where someone has been shot, they realize that this is not a crime scene, and police have their own regulations about certain things. Like if you go, you interfere in the crime scene. And how do you go about that?
And by the way, your question
But
is
also, secondly, in our case scenario here is that most people maybe not be having identifiers, because before you start doing anything, you have to identify yourself among the team. And my ID is here, I'm a doctor, I'm a health worker, I'm the right person to play the game. How did you start?
your question is not so different from what Charles has said. It's not very different. You should know the situation under which you're performing what you're performing. If a person has just been shot, maybe there's rioting ongoing, you should first save your life. The rest can come later. Because they are shooting everybody. And it is hard to know, especially in your this kind of civilian plots. If maybe you're putting on a clinical court, they probably think like, this one is a doctor. They may not shoot you because you're trying to save. I'm just saying. And let's not argue. Here, by the way, here, the orders are not very clear. You can identify yourself very nicely, everything you have. But because of the level of stupidity, I call it stupidity because there's no clear system. They'll kill you because you have identified yourself. Why should somebody shoot you when you're going to save a life? And now I'm also telling you, you should know under what circumstance are they shooting that person.
Firing squad.
You understand? You should see, is it really safe for me to approach them? Even if you have the best medical knowledge in this world, please save your life first. And then the rest will come. This one life, if it is gone, you will save more. You know, it is very hard to train a doctor to finish the course and get to practice. It takes you a lot of years. Then to shoot you 1 minute, you're gone. You understand? So you better save your life first. The rest can come. situations where you can approach it that way. If it is not safe for you, avoid and go do something else. People will understand. During the rioting here in Kampala the other time, they shot people. But I don't think any doctor stopped. Myself, I was driving from Gulu here going to Kampala. I reached where? These Wabules. Man, they almost stole my car and everything. But you can imagine I was risking my life also. Not that I had stopped to help somebody. But somebody got out of the car, just shot the person when I was seeing. I was just behind the they were driving government car, but there's a boss behind, there's a driver there, there's an escort there. The escort has a gun, the driver has a gun, the boss has a gun. All of them came out. Me, I was behind them. I didn't have any gun or anything. They just came, shot him, he fell there. I pounded myself, reaching in front, I found that put a very big barricade like this. Bobby Wine what that broke the road. Accidentally I knocked just the side of the, this portrait of Bobby Wine on the road. I knocked it just there. I came with a stone like I'm just doing like this, but when I passed that, so you gotta see, it's risky. You need to know when to approach situations. Okay, it's very, very risky. And where was that? You need to be safe fast. You need to be safe fast. The order, you can tell yes, we lost the doctor. It was in a crossfire. Crossfire, stray bullets. These statements are very rampant, and nobody will come back to look at it. But you'll have left your loved ones, everybody else, your friends, your classmates, lamenting and very distressed. Okay. Okay. Signs of somebody needing CPR. You're walking on the road, somebody you found collapsed. That's the approach. But I have got a framework how to approach such situation under BLS. Chest compressions, hands only, CPR. You are alone. You can only do chest compressions for this patient. Just do as much as you can. If you get tired, say because I'm tired. If you were able to get in contact with this patient within the shortest time possible and reverse back the heart, that patient will come back to life. Okay? Because the brain doesn't take that much without oxygen. You rectify, supply the brain with the oxygen, they begin to wake up. And when they wake up, they're breathing, oxygen now is flowing. The heart is now picking up, everything else is picking up. And before you know it, they'll stand on you, they'll walk and they go. Then you'll be like, man, today it was okay. I did my part. I saved the life. If you can't, the heart has returned, there's no breathing, then now do that piece of life with what you have. If you can do handkerchief, put on your like that. Okay. Because now you're only maintaining breathing. Because the heart is bad, you don't now need to compress the chest. You only now provide rescue breaths. Rescue breaths. Rescue breaths. Rescue breaths. Until the patient picks up. If you're two of you, one person does what? Chest compression. One person gives rescue breaths. When the person doing chest compression gets tired, you change immediately at the time when you're checking pulse and breathing. That is after 2 minutes. But I can dare you, you can never do CPR for 2 minutes straight. You think 2 minutes is small. Those are about 500 compressions in 2 minutes. It's too much. No, that's recommended. It is too much in terms of you getting tired. But that's the recommended for the first patient. Yeah, you can switch. You can switch. If your communication is good, be like, man, I'm tired, come. And if you don't just stop, come and take off. These are interesting things. If you do that, you are compressing the chest. If you do that and just stop, You are perfusing the brain very well. And then all of a sudden, the perfusion goes down, drops to 0. Then it will take you more time. 30 chest compression and 2 rescue breaths. That's the ratio, 30 to 2. 30 chest compressions and 2 rescue breaths. If you're 2, I'll do loud. 1, 2, 3, 4, 29, 20, like that. You have to make it clear. If you have reached 30, say 30, then the person does rescue breaths. 1, 2, then you go back. 1, 2, 3, 30. 1, 2, 1, 2, 3, 30. Like that, okay? That is how you do it. How do you switch? Yes. How do you switch? You can switch if this person is tired. For example, you communicate to your colleague, hey boss, I'm tired. You can come back and take over in 3, 2, 1. You get it? And you pulling out here, the person coming to chest compress will need almost 30 chest compressions before you give the rescue breath. So the person going to the rescue breath, you don't need to rush so much because you still have some time. And you come take over in maybe 5, for example. You will leave the rescue breath in 5, 4, 3, 2, 1. Move there and come here. You continue when you're tired again. You come take over in 5, 4, 3, 2, 1. Take over like that, like that. Communication is very important. Okay. Okay.
That rescue breath. I think in this situation, the person is going to need oxygen.
Yes.
But in the rescue breath, I think over 90% is carbon dioxide. Because what you give that patient is exhaled air from you.
Okay.
So I'm wondering if the rescue breath you are invested in oxygen, yet you're using your exhaled air which has over 90%.
No, that's not true. Are you sure what you're saying?
I beg to be corrected.
Yes.
Because the oxygen maintained is the one that could have remained in the dead.
That's okay. We understand we exhale carbon dioxide, but you have over 70% in your exhale air having oxygen. And that's why you give that oxygen to that patient. 70% is a lot. Room air, we have only 21%, and we are doing okay. You can imagine 70% of oxygen in your exhale air. You get the logic? Yes, there's oxygen there. It's a lot. And that will save the patient. If you want, you can pre-oxygenate yourself. Not a, you can pre-oxygenate yourself. By breathing in, out deeply, in, out deeply, in, out deeply. Not so. And then you'll have much concentration of oxygen in your exhale air, from 70 to maybe 80. But just as we are now here, if you test your venous air, for example, you'll find your PO2 is up to 70% and above. Yes, unless you've been in a carbonated room, you may be inhaling a lot of carbon monoxide or anything. In that situation, you'll be giving something else to the patient. But at least for normal circumstances, that oxygen in your exhale air is good enough. Yes.
Are there special appliances that you use for shocking? Are there
the shocking is becoming interesting, but we have got this is an automated external defibrillator. The battery is here. I've just removed it so that this you'll talk to
self-test. In case of emergency, press the green on/off button.
Okay. It will talk to you. So in case of an emergency,
If the orange button is flashing, press it.
Okay, right now it is flashing. Like it basically tells you what to do.
If the orange button is flashing, press it.
You're not pressing, but it keeps reminding you, please, can you do something? I'm not
If
pressing.
the orange button is flashing,
But anyway, we have this device. We have this device. These are automated, but we also have the manual. We also have the manual. And then now you are saying, when do we use it? When we use it, like for this one, it will tell you when to use it. For manual, you need to command it. You command it by you detecting the shockable rhythm. Okay, it is you who has the knowledge of the shocks, the shockable rhythm. So in the manual, you have to analyze the rhythm on the monitor. This is shockable rhythm, yes. Now you start selecting and shock. But this one, for the automated, tells you everything. Yes. But your goal is to apply it onto the patient nicely. We shall look at it. Time is going, but I beg you guys today, we might exceed maybe 30 minutes. We might, but it's good for you first. Okay, then there's this highly trained personnel, like the Code Blue team. We have multi-rescuer, coordinated CPR. Defibrillator.
Yeah. Like the situation that someone has just collapsed at home, and I think one of the principles to supply the electric current, they had to reorganize the electric charges which are
I'll give him time, please.
which are going to be running through the myocardium. So if I don't have a defibrillator, it's quite essential. Am I advised to connect some electric?
Yes, we shall look at the defibrillator. But which electrical appliances are you going to connect on this patient? You give me the answer. We also know you're not meaning battery.
Just get
electricity.
current, see whether it can reorganize the electric current.
One is, are you sure of the energy you have selected? Electricity. Or you're going to use on the patient? Okay. Secondly, have you seen that it is shockable? Have you detected it is shockable? Or just because you have that small physics knowledge, you want to use it on an individual that is not likely to survive either. In fact, you might actually kill that person in the process. What if the energy is too high?
240 volts.
What will happen? It's not advised. Never even, don't try it at home. Okay. Do not, in fact, I'm putting it in capital red letters. Don't try this at home. Even a bush. Just don't even think about it. But if you have everything in place, please go ahead and you'll see the outcome. Can we proceed? Yes. So in the high performance team, this is where you have multi-rescue teams, the Code Blue team. We come in numbers. We distribute roles, give ourselves this, communicate it back, then we start. After that, after this team have done their cardiopulmonary resuscitation, whether successful or unsuccessful, you come back to what we call coaching and debriefing. Okay, coaching and debriefing. Coaching is basically the CPR coach giving us how the CPR went, or the chest compression went. Was it done successfully? Was it well coordinated? Were all the qualities, all the high qualities of CPR executed? Okay. And then debriefing, everybody coming together. We analyze our roles. The timer, were they up to task? We also go back to the CPR. Were they up to task? We go to the airway person. Was the person up to task? We go to the defibrillator person. Was he up to task? We go to the IV meds. Up to task? We go to maybe now weaknesses and the strength we have seen in these persons, like the team. What were our strengths? Communication was very clear. Everybody understood his or her roles and responsibilities. Everything was done in time. We get into our crash cards. We had all our emergency meds. Right from the start up to the end, everybody was up to the task. Meaning, the patient passed on, okay, for example, okay? Patient passed on, but we were able to do all it took for us to do what we did. But the patient did not survive. That does not mean we did not perform well. We did well, only that the patient condition did not warrant return of spontaneous circulation. And so then you declare the person, maybe you have declared the person, of course, dead. Debriefing, you do it probably immediately after CPR or a few hours or days after. But in actual sense, it is better to do it immediately after. But trust me, in some situations, you have just finished the CPR. Maybe the outcome has not been successful. Patient has passed on, you have confirmed, okay? Then 2 minutes, another cord blew there. You don't have this time for debriefing, right? You don't have it. Said, okay, debrief, aborted or deferred, let's go there. We go there and resuscitate there. Maybe we shall resuscitate there and the patient picks up, and then that's okay. But also you prepare debrief for that patient and also this one. You keep documenting. In good situations, that's why this American Heart Association CPR book is updated every what? Every 2 years. Every 2 years, it's updated. They keep picking this data from your resuscitations. What did you do good? What was not done good? So certain things will be left out, even when it has been recommended. Like this is 2020 guideline. We still don't have 2023 guidelines. It's about, I think, to come. Normally it comes around May, September there. But it's about to come. So when it comes, we shall look at 2020 guidelines, what did they have? And then in the new guidelines, what was phased out now in the 2020 and what was maintained. Okay? You have so many guidelines. So record this information. It helps in your research. In your small hospitals, if you're the unit head or the medical soup, or the DHO, your potentials, you have to make sure this documentation is done so that when you come to data review, in a year, how many CPRs did we have? Maybe 80. Out of the 80, how many survived? How many died? Okay? Out of the 80, how many got complications? How many did not? How many were due to cause of this? How many were due to this other cause? And what were the outcomes? So all those, you can always be able to get the data, analyze, and then report. Then you have an updated version. For a country like Uganda, that should be already ongoing. That information should be there. As a country, we know in a year we have had this kind of, maybe in hospital or out of hospital cardiac arrest. And remember, the outcomes are always very bad for those outside there, that occur outside the hospital. Because they happen when you're not prepared, you don't have what to use, you don't have much time. They move the patient all the way from Palabek. You've been to Palabek. Possible. The patient is not breathing, not talking, no nothing. My flu is still disturbing. You move the patient all the way from Palabek to here. Very far. But those guys are confident. The locals, they do what it takes to take the patient to the hospital. The patient, of course, will arrive here dead. Pronounced dead GI casualties. And what do you do with that? When you try to ask the history, and then, of course, in your data collection thing, you just record this as death on arrival. Nothing much was done. If you have the history, that can correlate and lead you to something, maybe. Okay? Maybe this patient was operated 1 week ago, was discharged home. Home was bedridden for a few days. Then later on, out of the blue, started losing level consciousness. What would this assessment be? Bleeding would be one. Internal, maybe. Okay? Secondly, would be what? I would say patient was operated on 1 week ago. Then maybe laboratory. Was discharged home 2 days was home. At home, stayed for about 3 days. Not moving, bedridden. And then the attendant at home, when they were maybe giving breakfast, realized the patient was not talking, not moving, not responding to anything. And so immediately they picked the patient up in the hospital. The other one asked, you want to find out the cause of death here. Not so. What would be your cause of death here in this situation? Just said bleeding. What did you say?
Most likely.
Don't repeat what you are saying. Any other thing? Differential example. Yeah?
It could be complications of crisis.
Which drug? Which drug? What for 10 days? What's happening? Embolism. Very good. Nice. Okay, what else?
That's what I was.
That is what you were thinking. What else are you thinking about? Only. Give me differentials. Now we are distinguishing ourselves. The obvious are obvious. Not so. Not so. The obvious are obvious. But it shouldn't be obvious for the distinguished guests. Not so. Because if plan A fails, you go to plan B fails, you go to C fails, you go to E. Now we are in C.
C1.
A, B, C. Who is C? Septic shock, good. Now we are distinguishing ourselves. Another one? Yes. No, don't bring anesthesia here. Unattended death outside 24 hours post op, non anesthetic related. You get this point? Are you getting the point? I'm just now fixing it in your head. Yes, even you. Yes. Everybody else. Plan C. Septic shock. Okay. D. What? DIC. DIC, we would say bleeding. It's coagulopathy, not so. Bleeding. You're repeating our point, please. Plan D. Are you going to the VIP section or you want the general section? Along the way, don't bring along the way here. Leave along the way to along the way. Bring us right from home. Electrolyte imbalances, very good. What else, please? So I want you to have very wide kind of thinking, 360 degree. Okay? If this fails, and you have to be very, very fast in thinking in emergency situations. If you're this person who say, 10 minutes, you're still thinking of the same, just know you're going to fail this patient. This has failed, septic shock has failed, we are not okay, because you have looked at your parameters. Bleeding, patient doesn't really look pale. Could it be PE? Could it be electrolyte issues? So you take your sample. Send CBC, UDC, C-reactive proteins, all those things. Do your ABG. Could it be acidosis? Acute kidney failure? Was the patient passing urine, drinking, any fluid? You know, all these things. Please. You have to think outside the box, eh? Think outside the box, but within the box. You can't think of something else which is not like so much off track. Because now the relatives will tell you, you know, in the neighborhood, this person stepped on something, and that's why he got problem in the abdomen. And your surgical notes, You have reviewed the notes. It says the patient has got perforated, maybe gut, could be typhoid. Then for them in the village, he was bewitched because of there's some neighbor there. We want them to have been telling them not to go there, but they never listen. That one you just listen and let it pass the way the words are coming out of the relative's mouth. Then you try and treat the patient. And then if you have the time, try and explain to them medical benefits so that they don't go back home and hate their or their neighbors. Tell them facts. So main components of CPR, we have the chest compression, airway, breathing. Okay? You're able to see anything? Yeah. Just putting on specs. There are not so many. Are you able to see? Now here, adult BLS algorithm for healthcare providers. Healthcare providers. Here it says verified scene safety. Verified scene safety. Check for responsiveness in this patient. Shout for help or nearby help. Activate emergency response system. You can do it via mobile phone or you can just shout. Yeah, just shout your lungs out. Don't be nice to yourself. I know ladies would want to be nice. Help me. They'll be like this, oh my God. No, just shout your lungs out. And then if you have the AED, you get the AED and emergency equipment. Okay. Now you see 1, 2, 3. Now you come here. You have shouted for help. You have activated the emergency response. You have gotten your AED. You then go ahead and do what? Look for pulse or breathing. Look for no breathing here. Or only gasping, breath, and check pulse. You do this simultaneously. The patient is lying flat. If the patient is lying with face down, you turn them nicely, supine. And then check for pulse and breathing. Breathing, as you check for pulse, check for adults to do in the carotid. Carotid. You can touch your thyroid gland here, this protruding part. Mine is not majority of us. You have yours, which is like, that is like, yes. Which muscle is this one? Sternocleidomastoid. That's it? So as you palpate this up on Adam's apple, you just move on this groove here. In between the Adam's apple and the sternocleidomastoid muscle, that groove, you find what? Which pulse is that? The carotid pulse. You feel only on one side. As you feel that, you count at least 6 seconds, but not more than 10 seconds. Okay. You don't do this. 1, 2, no pulse. No, that's too fast. You have been, whatever the patient has got sinus bradycardia. Sinus bradycardia is going to be so slow. But you count at least, maybe you say, what can I use? Matthew. Say Matthew 1, Matthew 2, Matthew 3, Matthew 4, Matthew 5, Matthew 6. Even 6 seconds, you have not gotten a pulse. That means probably there is no pulse. If you want, go up to 10 seconds, but don't exceed 10 seconds. Okay? You don't exceed 10 seconds. If there's no pulse, then you say no pulse and you start chest compression straight away. I think, okay. Here, no breathing or only gasping or pulse not felt. You do what? Start chest compression in an adult in that ratio of 30 chest compression to rescue breath. and you use AED as soon as it is available. But if you've got normal breathing and pulse is also felt, then you just connect the patient on the monitor and record your parameters at that time. Here, no normal breathing, but pulse is present. You only provide the rescue breaths to the patient. You don't need what? Chest compressions. You only provide rescue breaths to the patient. But if there's no pulse, no breathing, you start chest compression straight away. If you're alone, if you're two, one person does chest compression, one gives rescue breaths. If you're many, this would be the roles. Chest compression, rescue breaths, getting AED, and all that. AED arrives, you check for rhythm and pulse. Non-shockable rhythms, you continue, chest compression, and then because this is BLS, you don't give meds here. Just chest compressions, rescue breaths, chest compressions, rescue breaths. If there is shockable rhythm, then you prepare your shockable device, select the energy, and then the machine will be telling you when to do the shock. This is what you do. I'm going to give a scenario. It's going to be verbal, but I would want one person to demonstrate based on what I've just said here. Okay? And this is how you're going to go through your BLS. Okay? I'll give you a situation or a scenario that you're going to deal with. And you can ask a class, mark that person. Maybe out of 10, for example. Okay? To give confidence. To give confidence. You get what I'm saying? I need somebody to volunteer. Because if I'm going to pick you random, you might be a bit what? Shaky. But for the entire class, to be in position to analyze whatever you're saying out of your confidence, then you can judge. Okay? Who wants to go first? Not Joshua today. Just to volunteer to handle the scenario I'm going to give. Matthew, you picked the point. Okay. Now, have a 65-year-old male. Okay? 65-year-old male, non-hypertensive. Came in from home with a history of severe chest pain. Okay? Rushed in the hospital at casualty with a history of severe chest pain for the last 2 days. You're the one at casualty to receive this patient. Okay? Start.
So, the first shape, I first see the patient's initials, and then I tap on the right. I get the patient, I tap on the shoulders, and I ask.
You have not done this. You have not verified the scenes, if it is safe for you to approach. Have you? Has he? You have not. Now I will tell you the scene is not safe for you to approach. The patient has vomited everywhere. You don't have any gloves, for example. But you're already touching on the patient. Okay? Okay, let's say now the scene is safe for you to approach. You have tapped on the patient. Okay, no response. I'm going to take off this.
Why? Yeah. So I tap on the patient's shoulder, since it's safe. So I tap on the patient's shoulder.
No response.
When I response, no response.
No response.
So if there is no response, I check for breathing and pulse.
No.
No response, I first call for help.
Call for help, okay?
As I am doing something.
With something.
If there is pulse, there is pulse and no more breathing.
No pulse and no breathing.
No pulse, no breathing. So what I'm going to do is start chest compression. So chest compression, 65 hours. I'm going to give that chest compression. If I have I give 30 chest compressions, 2 breaths. So I give like that until there is what? Until there is a response. But in the process, as I'm calling for help, we call for what? Someone to bring the
Okay.
Yes. So as I give the chest compressions, I'm going to, the EED is around, I connect the EED. So the EED is going to tell me whether there is what? Whether the rhythm is shockable or non-shockable.
You have connected the EED, it is non-shockable.
Non-shockable. So if it is non-shockable, I continue with my chest compressions. Why would give me what? Adrenaline.
Why are you bringing drugs here? We are on BLS. We are on BLS. BLS, I said there are no drugs, no advanced. Yeah, okay.
Just continue with chest compression. Chest compression.
2 minutes have elapsed. AAD has communicated, 2 minutes have elapsed. You need to check rhythm and pulse. Okay. You realize the shockable rhythm.
Now I shock.
You don't just shock. When the EED has told you, yes, the rhythm right now we have is shockable. You don't just go ahead and shock. No. You prepare now for the shock. By preparing, that means everybody else has to be alerted. You are preparing for the shock. Okay? You can then start saying, person giving a rescue breath, disconnect, clear off. Person on IV meds, clear off. Only remaining person doing what? Chest compression. And the person who is handling the EED can now take over the role of the CPR coach by saying, okay, chest compression, stop. Everybody clear, clear, clear. Shock. Shock delivered, yes. CPR coach gets back. Chest compression. Okay, that's how it is done. Now, you have shocked. You have given your first shock. Okay? Chest compression has resumed. Continue. Not easy, but we are learning. I'll give you a lot of time and you'll see.
So I've given the shock.
Chest compression is ongoing.
Yes, I'm giving the first shock. So I continue with the chest compression until 2 minutes elapse.
Yes.
Yes.
Now we are again checking rhythm and pulse. Okay. We are checking. It is still shockable. What do you do?
Again, prepare for the shock.
Prepare for the shock.
Everyone clears and then shock again. Second shock.
Yes.
So after the second shock,
you do what?
Chest compression.
Continues. Good.
Chest compression. After 2 minutes, we check the pulse.
Pulse and rhythm. Yes. Now rhythm is sinus, rhythm, normal.
So we give sinus rhythm, we just now continue chest compression and then epinephrine. So at that point, you give epinephrine 1 milligrams, then you continue chest compression.
Please, no, don't do that.
No drugs.
What do you do? First shock, second shock. Now what we are seeing on the monitor is normal sinus rhythm. What do you do next?
Ventilation.
Ventilation. Okay. Ventilation. You understand? Don't follow that. That sensor is just in case you're still shocking the patient. But the shock is to revert back the heart. Now you have given just 2 shocks was enough to revert back the heart to the normal sinus rhythm. So now here you connect the patient, just ventilate the patient. As you're trying to find out the cause. Have you been actually thinking of what could have caused this? You are just on sensor. But you're not thinking of what could have caused the cause. I've given you 65-year-old, non-hypertensive, not on meds for some time, with severe chest pain for the last 2 days, came in the hospital. What would be your Diagnosis.
Angina.
What do you think now?
Angina.
Boss, can you say something to that? Angina? Could be angina, could be myocardial infarction or ischemia. The angina could be what? Is it stable or unstable?
Unstable.
Why unstable? Why not stable?
There was no exertion.
There was no exertion probably, and being non-hypertensive, and this is a senior citizen, 65 years. Yeah, it could be unstable angina, unprovoked, just present. For stable angina, you must have been active for some time. If you climbing the stairs, then you should present with that. So as you think of that, then how do you manage that? That is under acute coronary syndrome, not so. What are the management there? Nazi. Internal medicine. You have not been doing internal medicine? Mr. Sam, right? You are? No. You're Moses, you're just saying, I read this thing last week, but that's disappeared. So you need to probably thrombolize these patients. There could have been a micro thrombus there. Thrombolize them. What are examples of thrombolytics? Thrombolytics. Example. The guy is wondering, like, this morning I woke up, I was not feeling well, I wish I'd stayed in bed. Say, thrombolytics, example. Sorry? No, I'm still on him. Just one example. I give you one example and then you continue the next. Yes. You're just dense. Okay, who wants to give us? Example of thrombolytics. Aspirin. Is it a thrombolytic? No. Huh? But do you have thrombolytics? Yes. Are you going to give aspirin for the side effects or to treat the thrombus? Huh? We don't know, eh? You have a question or answer? Can you answer me first? Then you ask your question. Thrombolytics. Not suffering. Is it a thrombolytic? Please. Excuse me. Strepto? Lysis? Streptokinase. Have you heard of tenecteplase? Alteplase and all those? Yes. And it's speaking the truth. Don't be for us and that. It makes me think twice why you're putting on it. Okay, so yeah, you can then thrombolize your patient if you have it. Thrombolize them and then put them on those antiplatelets. Yes. But you what? Yes. Now that one is for prevention of clots, not for treatment of clots. You get the difference? Even enoxaparin, for prevention of clots, anticoagulant, not the thrombolytics. You can never use it to already dissolve, already formed what? Clots. No. But there are those that work immediate on those clots that have been formed. Thrombolizes them very fast. These are what we are talking about. And they are not cheap. They are money that you can use. It's like it's a lot. A dose, single dose like this is almost 3 million. Yeah, you need to be somebody's son or I don't know, daughter to afford it. You know, health is expensive, but You can save who you can save. Diseases don't read books, eh? If you have identified the problem, you know what to use. But because of the system failure, you cannot help the patients. But you can refer them if they can reach. Recently, I had a patient who had intracardiac thrombi. And this patient, we didn't have the thrombolytics, they were out of stock. But we had to refer the patient for thrombectomy. You cannot thrombolize intracardiac thrombi. Because if you thrombolize, they'll break down into micro thrombi, which can be thrown up, even into the brain. And it causes very bad. So it is better to just remove the clots from within the heart, the way it is, out, so that you don't break it. You can only break it into the vessel. You think it is rocket science? That is what happens. Okay. That's the question, eh?
But if I think in that session, that coronary syndrome is part of the hypertensive emergency.
That?
Because it's part of the hypertensive emergency.
Which one?
I think coronary syndrome. Because hypertensive emergency also presents with coronary syndrome.
Hypertensive emergency. Yes, it is possible, but now that tells you from whatever blood pressure you're going to get at casualty. Right? You're just saying, but whatever you get, if it is possible, yeah. You don't have to look at the ways of first controlling that blood pressure and then also rectifying that chest pain is resolved and rule out the other possibilities of infection. ECG, cardiac enzymes, look at them. Because on acute form, the cardiac enzymes may not show much. The troponin IT and whatever, COKP, may not give you much information. But you can repeat after about 6 hours. Okay.
Excuse me, doctor. For a scenario where you can actually auscultate the pulse, but you can't feel it, and the chest is not moving, what do you do? You go for CPR or just lay here?
You auscultate, but you can't feel it.
Yeah, you can't feel the pulse.
By the time you are able to auscultate, you must feel it centrally.
Okay, periphery, you
can't feel it. That's why we go for the central pulse. If you can feel the pulse, that means the pulse is there. So you don't need the chest compression. You only provide rescue breaths. You get the point? You provide the rescue breaths because you're feeling the pulse. I would have gone for the radio pulse, for example. Why am I not going there? Because I know I may not get it, but when the pulse is there centrally. Yes, if it's there, just give the rescue breaths. Because the chest is not moving, but the pulse is present.
Doctor, which one is better, like oxygen, real oxygen, oxygen machine, or just bags?
What do you have available? Go for the best. You can't stop this patient of oxygen just because you want to, unless you're doing research, which is quite really risky. Even the Gurek may not even approve your proposal. You're denying somebody oxygen, and that's the source of life in the name of research, and the patient dies. I don't think we shall approve that proposal. But if you have the oxygen available, give the patient oxygen, 100%, not even the medical air. The medical air is just purified air, which has got no purities. It is just clear, just like the atmospheric air, but well purified. Did you understand?
It is a bit confusing because you're giving oxygen, but carbon dioxide is not moving down because the chest is flat. It's not moving. Just giving.
The chest is flat.
Yes. It's not moving, but the pulse is there.
Okay. Okay. But can you make sure the chest moves? Maybe your technique is the problem.
No, I'm like, okay, one day we had a patient, 6-year-old, severely wounded. And we came in the patient, the chest was not moving. But when we tried to check for the pulse, and the radio wasn't there. Then on auscultation, you get the pulse.
You got the pulse, yes.
The chest was flat. like not moving.
Mm.
And the patient was already on the rebreather mask or oxygen.
Rebreather.
Yes.
But was the patient conscious?
No.
No. Can you intubate that patient? Put an advanced airway. Because when you're giving the oxygen to the patient should then be in position to pick that oxygen to the lungs. Now, if the patient is not breathing because the chest is flat, can you breathe for the patient? That's what I'm saying. If you're bagging just using an ample bag, can you breathe for the patient and make sure the patient's chest is rising and falling? If that's not possible, because your technique of putting the mask is an issue, can you put the tube inside, into the trachea, and ventilate the patient easily? Did you really save that patient?
Actually, the pulse was there, but it got tired.
Obviously, the reason as to why now when you get the pulse and only give your oxygen to the patient is to maintain that pulse. For as long as you're able to maintain that pulse, because you're giving oxygen to the patient will survive. But now if the oxygen is not being given to the patient, the pulse is going to go off. Hypoxia is serious. First of all, you get into tachycardia, then later on you get into bradycardia, and then asystole, and death. Yeah, you get my point. So you should have secured the airway, or at least call the anesthetist if you are not having that knowledge of intubation.
Actually, here at emergency, I don't know, but by then we didn't have those things there.
Quite unfortunate. Maybe the system failed. Are you sure you could have intubated if you had everything you needed? Yeah, that's also another thing. And now, if everything was in place, you could have called the anesthetist from theater to come maybe with the ETT, laryngoscope, intubate there, and then the rest continues. As you secure the airway, pulse is there, everything is taken care of, you write an emergency transfer. You don't have an ICU here, let's go to La Chom. I mean, if it is not possible there, ICU is full, Mulago. Referral is management, it's part of management. But you don't kill a patient just because. No, not acceptable. But you had not digested all the options. Yeah. You are limited in your thinking. That's what I've notified in what you're presented. Because theater, they have all those equipment. You could have called them to come over.
I'm the patient. I'm kind of confused from the scenario that you gave.
Okay.
The emergency unit. We have this primary care ABC, and we have this basic life support. Assuming they are victim accident.
Victim.
And they are, I mean, for what accident?
Yes.
They have been brought.
Yeah, mass casualty?
Emergency.
Okay.
The basic life support, and then the other ABC.
Yes.
One counts.
Basic life support and the ABC, like the primary survey and secondary survey, which one comes first. What you do, in this case, I would imagine if your patient is responsive or conscious, you go with what? Primary survey. Okay. Primary survey. Yeah, if the patient is talking back to you, meaning the airway is parted. Now go for the breathing. The patient breathing. If the airway is parted and the breathing is abnormal, but make sure you secure the airway by maintaining it parted now, not the patient to lose it. But just in case, to make the two difference, patient is unconscious, go with BLS. Patient is conscious, go with primary survey, ABC. Then later on, secondary survey. That's what it is. Yeah. Any question? Are we comfortable with what we have just discussed? Should you mark this guy now? Eh? You're marking yourself. He's saying 7 out of 10. No. But you tried. But with many examples and scenarios. you'll be able to take it. In fact, yeah, that's a very good question. Why, when do you go with BLS, when do you go with primary survey? That is the difference. Patient is talking to you, conscious, go with primary survey. Patient is unconscious, go with BLS. This is where you check for the pulse, for the adult. For children, you can do 3 areas. You can do, actually 3 areas. You can do here, carotid. You can do brachial. You can do femoral. Just because those bodies are small and there's not much distance in terms of the heart pumping blood. It's within a short distance. So you have 3 areas for children. Here, brachial, and then the femoral artery. These are the qualities of a good CPR. Compression rate of 100 to 120 per minute. The depth should be about 2 inches. That's 5 to 6 centimeters. And you allow complete chest recoil. You also minimize frequency and duration of interruption. That's interruption, And compression to ventilation ratio for adults is 30 to 2. For children, it is what's the ratio? Who is saying what? Can I hear somebody saying something? Honorable, can you say something to them? For children, compression to rescue breath ratio. You don't remember? Who remembers? I want to look for somebody who has not said anything since we started. At least for this lecture. Cleophas, as the class president. Three to one. For neonates? Yes. Who is a neonate? How many months? Below 1 month.
0 to 28 days.
Below 28 days. Or 28 and below. Okay. Is considered a neonate. An infant?
2 years.
1 year. 1 year.
Huh?
1 month to 1 year.
It is 1 month. It tells that you complete 8 days to 1 to a year. 12 months.
Okay. I have so many stories, but let me not bring them right now. So, and children? It's your time. You just shy for us. Because if you tell us there's no projector, we shall listen and say, class president has said no projector. If it says children is this year to this year, we say, class president. Children. Because if you're able to categorize this, it will help you to determine the chest compression to rescue rate. So we have known neonates 3 to 1, right? Children 15 to 2, adults 30 to 2, and children now start from, let's say, from infant point and above. There are some people, you look at them, they're like 25 years, but actual sense, in reality, they're about 12 years, 11 years, right? They are out there. Children who look so big, physically they appear so big, but age-wise they appear as adults. Those when you go, you treat them as adults in cardiac arrest, 30 to 2, because their body mass is quite big. Yeah. Now chest compression techniques. Position yourself at the victim side. Position your hands and body to perform chest compressions. If the patient is, let's say, on this table, you're on the patient's side, with your hands, give chest compression at that rate, and you have to give that depth of 5 centimeters, 2 inches. Then at the end of each compression, you allow the chest to recoil completely. So avoid leaning on the chest between compressions. You're there pressing, you're not coming out, you're just quivering the entire chest. That's not chest compression. You're basically strangling that patient now. Strangling them through the heart. You get what I'm saying? Because you're not allowing the blood to pull back, the chest to recoil back, so that you can pump and supply the oxygen to the other vital organs. How long does your brain take without oxygen, Brenda? How long can you stay without oxygen?
4 minutes. No, 10 seconds.
10 seconds. Can you define for me what an apnea is?
Cessation in breathing.
For
20 seconds.
For 20 seconds. Now, if you cease breathing for 20 seconds and you can restart breathing in 20 seconds, does that mean your brain has died and resurrected?
No, that's not true.
So does the 10 seconds work?
No, they don't work.
So that means the class, she's a what? Aaron.
Academic secretary.
The secretary is giving us a lie.
Yes.
Who can define for me? How long can you stay without oxygen? Your brain can stay without oxygen. Huh? Huh? Hey, boss. Let's discuss together, boss. Help us understand this. Huh? I saw you are really emphasizing on the point. How long does it take? Yeah. So what were you telling him? It's like you are refusing. Not so.
I went to talk to you.
What do you know? What's your view? Okay, I'm not asking for your view per se. View is for professor and the rest. What did you read? I'm not hearing him. Have you had it? Excuse me. Talk, we are together. So who was telling you 5 minutes? The way you guys are smiling, you just don't lying. You're sure of the 5 minutes? You're not very sure. What's your name? Huh? Fedris. Do you agree with them? I saw your hand up. Go ahead, tell us.
The brain after 4 minutes, it will have a permanent brain damage. Then after around 10 minutes, it will have brain damage.
Who can educate us today? President, you're also here. Chief. Yes. Tell us.
I remember 3 to 5 minutes.
3 to 5 minutes. You remember from where?
I don't remember that song.
3 to 5 minutes. Okay, yeah. So roughly, I would say maximum 5 minutes. Beyond that, we'll have died. How long can you hold your breath? How long? Have you ever tried holding your breath? How long can you hold? Okay, let's say those who know how to swim. You go under the water.
Yes.
For how long can you stay under the water? Have you ever timed yourself? 45 seconds. 45 minutes. Second. You can do 45 seconds. Some of you just 2 seconds. But anyway, about 5 minutes. Without oxygen to your brain, you're gone. So time is very, very critical. That is why majority of our patients who get cardiac arrest out of the hospital have poor outcomes because they can't sustain hypoxia for long. They'll die. In the hospital settings, you have what it takes to rescue them. Oxygen cylinders, maybe the wall oxygen, or just the concentrators, or just an ammo bag, or even yourself, because you're medics, you know what to do, mouth to mouth, face mask, everything. You can do something to give oxygen to this patient. That's why survival rates are high in hospital, cardiac arrests. And you minimize interruptions. Interruptions in terms of if somebody is doing chest compression, the person analyzing this, rather using the defibrillator, will not just stop chest compression. Or even somebody doing chest compression will not just stop without informing the rest. Likewise, if you're to intubate or secure the airway using an advanced airway equipment, you're not going to take so long intubating the patient, and you must be very good at airway. You can't go do laryngoscopy. You know what this is?
What is the latest?
This is laryngoscopy. There are different types. You do your laryngoscopy. Some people hold it in this hand. They can't see nothing, and you're there wasting time. Patient is saturating. When the heart has stopped, we have given you 10 seconds to intubate this patient. But just taking the blade inside the mouth has taken you 10 seconds, and we need to give you 10 more. Before that, you're in 2 minutes. Nah. Patient will just follow. The patient will follow you wherever you go. With their curses. Okay. So you minimize interruptions of chest compressions. How do you place your hands? They call this is more of a layman language. Breastbone. Huh? It is a stand. For us, we call it stand up. If you can't understand, that is your problem. You have done anatomy, my friend. We need to use this word. Stand up. So the lower third is the stand up. So you're going to place your hand. Okay? For children, you can actually use one hand. Those who have slightly bigger body mass index, you can use just one hand to compress. For watu kama sisi, who knows Kiswahili here? Who is Kenneth? What is Kenneth? You know Kiswahili? You know, eh? What have I just said? Mutu kama sisi. Mutu kama sisi.
Someone like us.
People like us. Someone like us.
So anyway, yeah. So people like our sizes, eh? We can use 2 hands, not just one hand like this. You may not. For those that I can use only one hand, they are not so. No, I need 2 hands on you. So 2 hands. Okay. This way you're going to place your hand. How will you be on the patient?
That's too much energy.
Are you seeing this alignment of the hand? This straightness here. Where does the weight come from? From the shoulder. It should not come from the hand. And that is why when you do chest compression, don't bend these elbows. Especially for adults. You should make it straight. As you go, like this. Straight, not bending. If you bend, that means the weight is coming from the hand. And you're going to give inequality or poor quality chest compression. It must be strict. You can interlock your hands. Okay? Or the lower hands can be the most dominant. If you're left-handed, you can do the left. But normally I like doing this. You can interlock and then using the heel of your hand, of your palm, press it on the breastbone, the lower third, and then it comes from the shoulder. You don't bend your hands. And be as close as possible to the patient. And mind you, let's say the patient rests here on this table. It is going to be very hard for you to do chest compression like this. You might need something that would raise you up, or at least put this patient down and just kneel on the side. But it has to be a flat surface. This is another technique. Just one hand, put on the lower third of the sternum, straight, then the other one, hold it here, as you do, especially for children, maybe. That's another technique. Now for pregnant mothers, in maybe multi-rescue wards, one person can be on the side to just displace the uterus, left uterine displacement of the uterus, the gravid one, especially beyond 20 weeks, because the pressure on the abdominal vessels is going to be marked if you don't displace, and so perfusion to the brain will be less. Then others will be wondering, now how about the child? What will happen to the child? What will happen to the child? When the child dies? The child cannot die for as long as you're ventilating or oxygenating the mother, the child will get the oxygen also. It's automatic, not so. So you just make sure you rescue the mother, then the child will also be rescued automatically. But avoid this compression on the intra-abdominal vessels. So you can do one hand technique or two hands technique. You displace it with the two hands. For pregnant mothers, you have done your spinal. You have caused total spinal. Then you need to do CPR in this mother. What do? This is what you do. Okay? Total spinal. You have not heard of total spinal? Is it possible you can get total spinal?
Yes.
Yes. As a complication or poor technique of your spinal anesthesia. You do what? No, you compress. Now the person doing the displacement is different from the person doing the chest compression. The displacement is to help just the venous return to be good, and also the abdominal aorta not to be compressed. But the chest compression continues. Yes. Now the airway techniques. How to do the basic airway. The head tilt, chin lift, and jaw thrust. You have heard of this, eh? When do you do this? If the patient has got signs of airway obstruction. Maybe the pulse is there, but now you need to make sure the breathing is okay by opening the airway completely. So you do the head tilt and chin lift. Just that, chin lift. If you have the airway equipment, the OPS, give me that yellow. This oropharyngeal airway. This oropharyngeal airway, you need to measure it that it fits your patient. You know how to measure? Geoffrey, why are you doing this? Are you making a sign of the cross or something? Talk to us.
Okay, I was meaning that you measure from the front of the mouth to the anthem of the ears.
The triggers, eh?
The triggers.
Everybody has understood. This is how you're going to measure. Now, I'm assuming this is what you're probably going to use on your patient. But before you, because what normally happens, the tongue is the object or the organ that obstructs the airway, right? Now you want to open the airway. And by opening the airway and securing the tongue, you probably need to put this oropharyngeal airway so that it prevents the tongue from falling back and obstructing the airway again. The patient can still be breathing adequately, even the pulse is there, but you're just maintaining the airway. By doing, you've already done the head tilt and chin lift. But the tongue can fall back from inside there. Even when the head is in that position you have placed. But then you can put this airway equipment and prevents the tongue from obstructing the airway. So you can measure from this point, from this angle of the mouth to the trigons, or the TMJ, right? Temporomandibular joint. That's where it ends. If it goes beyond, it means it is too big for your patient. You choose another one. If it is too big for your patient, you're likely to put it and obstruct onto the laryngeal outlet. It blocks on the laryngeal outlet, and your patient won't breathe. If it is too short, the base of the tongue can still fall back and obstruct the airway, even when the upper part is parted. So you rather use the right size for that particular patient. Not too short or not too long, but the right size. This is what you do. Head tilt, chin lift. Chin lift. Okay. It's a combined technique. Head tilt and chin lift at the same time. Yes.
Doctor,
This one?
will I be right if I put in for every unconscious patient?
This one?
Yes.
You're actually going to be right. One, you put it there and make sure your patient's airway is numbed, is not very active. Okay. Like what I mean is they do not have cough reflexes. Like not irritating the airways. Because they can cough it back and they won't tolerate it. So if your patient is unconscious, you put it in there to be able to tolerate it, to not cough it out. And then as you put it in there, through this other opening, you can actually do suctioning of saliva maybe, if it's there. So that you make sure there are no microaspirates getting into the lungs. This is jaw thrust. The technique, the steps you do, position yourself at the patient's head. It is a painful maneuver, this one, jaw thrust. But for unconscious patients, they don't feel the pain. So you can do it comfortably and the jaws are relaxed. So you can move it easily up and down. Here you're pulling both the bony prominence and the tongues out of the airway. This is what you do. This is where you grab. You're not going to grab on the soft tissues here. Make sure your hands are lying on the bony prominence. Here. Grab it there at the angle, TMJ there, pull it. These little fingers, see, like on this other side, they'll go on a bit inside. This one is holding it right at the angle. Then these other three fingers, the ring, index, and the middle finger are just on the bony prominence to firm your grip. Then you can pull it through. Now, the mouth-to-mouth maneuvers you are talking about, these are pocket masks that we now use to avoid risk of infection. So you can use this mask. And here, the person is demonstrating it very nicely now. You blow the air through, you just connect your mouth onto this and make a good seal. Make sure there's no air leak on the side. So that as you blow, beside the mouth seal here, the seal also on the face should be tight enough. So that as you blow your air into the patient's lungs, they are not leaking outside. And you can see the chest rising and falling. Rising and falling. And they give you rescue breath through that. Now, the size of your masks. This is how you determine it. It should come